Hi there, my name is Mike Sullivan. I'm the Program Director of Valor Medical Services. I'd like to welcome you to this presentation from our series of continuing education for pre-hospital providers. Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Hi there, my name's Mike Sullivan. I'm one of the instructors at Valor Medical Services, and welcome to ECG Interpretation 2A. In this program, we're going to be recalling some of the core criteria for ECG interpretation that we covered in Module 1. We'll also be discussing several rhythms and describing the criteria associated with sinus bradycardia, sinus arrhythmia, sinus tachycardia, and supraventricular tachycardia. We're going to then go on and explain the clinical significance of each of these rhythms and go over different ways that we can differentiate between sinus tachycardia and supraventricular tachycardia. But before we get in too far, let's go back and recap what we covered in Module 1. We talked about 5 key rules or key criteria that we would apply to an ECG to determine what the actual rhythm was. These 5 rules were the rate. We expect to see rates that are normal between 60 and 100. We'll talk about regularity, how a rhythm should march out. It should be regular. QRS should happen in regular intervals. We'll talk about the PR interval and how long it should be. The QRS width, how wide it should be. And the P to QRS ratio and the P wave appearance. Now, we applied these rules to a given ECG rhythm and determined based on the criteria that it was indeed a normal sinus rhythm. So now let's go back over what the normal criteria are for a normal rhythm. A normal sinus rhythm should have a rate between 60 and 100. It should be regular. It should march out. There's several ways we can go over that. Just seeing the distance between R to R intervals, seeing if there's a set number of beats throughout the whole rhythm. We should have a PR interval of less than 0.20 seconds. If you recall, that was 5 of the small 1 millimeter boxes. We should have a QRS width of less than 0.12 seconds or 3 small boxes. Lastly, we talked about the P to QRS ratio and P wave appearance. Should have a 1-to-1 ratio between P waves and QRS, and all the P waves should be consistent and upright in appearance, indicating the rhythm originated from the same place. So as we go on now into different rhythms, let's look at some other EKG tracings. Once we determine what a tracing is, we'll discuss some of the pathophysiology behind it and potential clinical significance of this rhythm. Now please keep in mind that not every abnormal rhythm or everything that doesn't fit perfect normal represents a significant clinical problem. In some cases, a dysrhythmia may be totally normal for that patient. There are many patients walking around today who would have an ECG rhythm that is not textbook normal, and we need to understand when this means something and when it just happens to be a little bit different. Alrighty, now let's dig into some rhythms. We look at our first rhythm there, and the first thing we want to do is, again, look at our rate. Now, there are several ways we can determine what the rate would be on this rhythm. we can go through and we can count for a 6-second time gap. So let's say we start at this first marker right here, and we count out 6 seconds, which would be 1, 2, 3, 4, 5, and the 6th mark would be right here. So if we looked in between this 6-second gap, we'd see 1, 2, 3, 4, about 4 QRSs, about 4.5 QRSs. That would tell me it'd be about 40. If I went to look at it a different way, if I marched it down from here, if this is on about the heavy yard line here, we'll say 300, 150, 100, 75, 60, 50. That's definitely less than 60. So by two different methods, we'd say it's about 40 to 45. Well, if we go one step further, we'll check it here, and sure enough, it's running about 40 beats a minute. And if we go to the top now, we would see that the monitor actually concurs with us at the 40 beat a minute mark. Now, let's look at the rhythm. Does it appear to be regular? Meaning, is the gap from, say, this R wave over to this R wave consistent? Is the gap between this R wave and this R wave here fairly consistent? It appears to be consistent. I don't see any significant variation throughout. So we'll now declare this rhythm to be indeed regular in nature. Let's look now at the PR interval, and we'll zoom in a little bit to see. If we look at the mark between the red dot, or the distance between the first red dot and the second red dot here, it appears that we have about 4 of the small boxes in there. So if each one is 0.04, that would be a PR interval of 0.16 seconds, which is indeed less than 0.20 for a PR interval. Now let's look at the QRS width. Again, we'll zoom in a little bit, and we can see that it appears to be about 2 of the small boxes between the green marks here, giving us a PR interval of 0.08 seconds, which is less than 0.12. So, as we come out a little further, let's look at the P's and the QRSs. Well, there appears to be a P wave for every QRS and a QRS for every P wave. So we can say that we have a 1-to-1 ratio. Beyond that, do all the P waves appear to be about the same and normal and upright? Yes, they do. So we'd say that all the P waves appear similar. So we've got a rhythm. The big difference is it's got a heart rate under 40, but everything else fits the normal criteria. So based on that, what would we say this rhythm would be? This would be indeed sinus bradycardia. It meets the other 4 rules of a regular normal sinus rhythm. The only difference and variance between a normal sinus rhythm and a sinus brady is it's under 60 beats a minute. So now, what would the clinical significance be of a sinus bradycardia? Well, much is normal about the rhythm. It's a little bit slower than expected. Now, sometimes a sinus brady can be very normal as far as a well-conditioned adult, somebody who does a lot of aerobic activity, whether it's running, CrossFit, things like that, anything where their cardiovascular system is extremely well tuned up. Now, 40 is a little bit slow, but seeing those individuals with heart rates in the low 50s or high 40s is very normal. In other cases, this could be far more serious. So let's look at the patient condition. Some of the questions we want to ask ourselves in seeing this rhythm is the patient showing a sign of shock or poor perfusion? Are they having altered mental status or syncope? Are they not perfusing their brain adequately? Are they experiencing chest pain? Are they experiencing signs of heart failure, such as pulmonary edema? If none of this is true, the patient's got no signs of shock or poor perfusion. Let's say they've got a strong radial pulse. BP is 110 systolic. Their mental status is totally normal. no chest pain, no complaint whatsoever. Let's just say we're treating them for an isolated orthopedic injury, and they appear to be very athletic. This could be totally normal for them. Now, on the other side of the coin, if this patient is a 50-year-old male couch potato who's 110 pounds overweight and experiencing chest pain and difficulty breathing and having trouble keeping their eyes open, that would be very, very clinically significant. So again, evaluating sinus bradycardia, yes, it can be normal, it can be abnormal, and so much has to do with actually evaluating the patient's presentation far more than you can get by just looking at an EKG strip. Alrighty, now let's move on and look at another rhythm here and see what we can come up with. Alright, looking at that rhythm, what do we see? Well, let's start by applying our basic rules. If we go back to fundamentals, we say we want to march out and determine how long a rhythm strip, or how... Alright, let's move on and try looking at some other rhythms and see what we come up with. Ooh, let's look at this one here. Now, as we look at the monitor, again, the first thing we want to do is determine what the rate is. Now, as we look at this one, we see the rate here. If we start with the first one, okay, we're going to say, starting from this marker here, we'll count out 6 seconds. 1, 2, 3, 4, 5, 6. We count back and we say, okay, we have 1, 2, 3, 4, 5, 6. All right, about 60. We'll make between 60 and 70 beats a minute, I'd say. And we keep going through. We confirm with the monitor. What does it say? 68. Okay, between 60 and 70, we were fairly close. Now, does this rhythm look regular to you? Does the gap between this QRS complex and this one look the same as between this one and this one, or these two over here, or maybe these out here? No, it's kind of irregular to me. It looks to be very irregular. So that means we know that the rhythm wouldn't qualify as normal sinus rhythm. It's got to be something else. Now let's look a little closer at the PR interval. Well, as we look at the PR interval there, it appears that it's going to be about 3 little bitty boxes, maybe 4. I'll give it about 4 there. So based on that, it's going to have a PR interval of 0.16. When we look at the QRS width of it, we'll see that between the 2 green markers here, we've got about 2 boxes of the smallest, so that would be 0.08, which again would be narrow complex QRS, less than 0.12. And now let's look at the P to QRS. Now with an irregular rhythm, we need to look very closely at the P to QRS ratio. We have a P wave with a QRS right behind it, another P wave with a QRS, got another P with a QRS here. Seems that every time we have a P wave, we've got a QRS following right behind it. And of course, every time we have a QRS, it's preceded by a P wave. That's a good sign. So we'd say that yes, it's 1-to-1 ratio, and all the P waves appear to be pretty much identical, so I'd say it would be similar enough. So now, what would we call this rhythm? Well, it's a sinus rhythm because it has a P wave. It has a P for every QRS and a QRS for every P. So it would be sinus arrhythmia. Now all this is a sinus rhythm that has some slight irregularities to it. The PR interval is still consistent within less than 0.20 seconds. All the P's have QRSs and all the QRSs have P's. The rate is about 70 beats a minute, and so this may or may not really be clinically significant at all. When we look at sinus arrhythmia, you may also hear it called sinus dysrhythmia. Now, arrhythmia technically is lack of rhythm, and dysrhythmia would be a difficult rhythm. Either way, it's a slight variation of regularity, cycling off what's otherwise a very normal sinus rhythm. Although much is normal about the rhythm, it may be slightly slower sometimes, given how it varies based on regularity. And sometimes it may vary with respiratory cycles. You may find that patients on inspiration having slightly slower rates than they do on exhalation. You may notice how it varies. It may be normal in infants or younger children. Overall, it doesn't present a significant clinical issue at all. Let's look at how the patient's presenting. Are they hypotensive or are they normotensive? Are they perfusing adequately? Is the heart doing its job? Okay, it's a little bit irregular, but is it doing its job? Is it perfusing the body? Do we have a good BP? Do we have good mental status? If we do, we can note that we have sinus arrhythmia or sinus dysrhythmia, but nothing clinically significant about the rhythm. In many ways, this rhythm is an excellent example of a patient who, although they don't have a normal rhythm on the monitor, it could be totally normal for them, and it wouldn't be clinically significant. It's nice to note, but that's about it. If I was talking to the ER staff or calling in a report, I'd tell them to have the patient on the cardiac monitor showing a sinus arrhythmia of about 60 to 70 beats a minute, but perfusing well. This would let them know that, okay, the patient's not textbook normal, but the rhythm is not causing any problem, nor is a sign of a problem, so we can move on from there. Now let's look at another rhythm. Ooh, this looks a little bit faster. It looks like we've got a lot going on here. Let's see how it all works out. Well, if we're going to start by trying to figure out how fast this rhythm really is. Let's start off and say, alrighty, from this mark right up here, I'm going to make a mark there. We say 1 second, 2 second, 3 second, 4 second, 5 second, 6 second strip comes to right there. And we count back, say how many complexes do we have? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. We've got about 13 complexes there, 12 to 13, depending on that gap. So we'd say, okay, it appears to be about 120 beats a minute, I'd say. All right, if we want to go look at it a different way, we can take from one of the QRSs that's right on the line. We'll say this one here, we'll use the countdown method now. If this one would be 300 to this line, and 150 to this line, and 100 over here. So it's between 100 and 150 beats a minute. So again, about 120. I can definitely live with that. We look up on the monitor here, and again, it's going to confirm for us 120. Now, let's look at it. Does it appear pretty regular? Well, there is a funny little gap right here where it appears that it gets almost an extra beat in there. But beside that one extra beat, everything appears to march out pretty well throughout the whole strip. So I'd say that this is overall a fairly regular rhythm. If we look at it, look at the PR interval. We'll zoom in a little here, and we see the PR interval is from here over to here. So I'm going to say that's about 3 little bitty boxes, and that would be 0.12. If we look at the QRS complexes, nice and narrow, it's from here to here. So it's about 0.08 seconds, or 2 little bitty boxes. Now we come down and let's look at the P's and QRS's. Is there a P wave for every QRS, and is there a QRS for every P? It appears to be. Again, there's a little bit of an abnormality right in here. I'm not sure exactly what that is, but when I look at overall with 10 or 12 second long strip, to me that one abnormality is more likely either a bump in the road or something minor. Could be a little paper jam there, I'm not sure. Overall, though, I would say it's 1-to-1, it's regular, and all the P waves appear to be pretty similar. So now we have a rhythm that fits all the criteria, with the only departure from that is the 120 beats a minute. We know normal sinus rhythm has to be between 60 and 100 beats a minute, so what would we call this? Well, how about we go with sinus tachycardia? Now, sinus tachycardia is one of the more common rhythms we'll see. It fits all the normal criteria, however, the rate is just over 100. So, much like its predecessor, it only misses one of the criteria. This one's actually normal than it should be, based on the patient's age range. In the majority of cases, this rhythm is not caused by a cardiac issue. It can be caused by something else within the body, some other underlying issue the body is compensating for. So if we're trying to address or figure out what's going on with sinus tachycardia, we need to look for and try to treat an underlying cause. Some of the most common causes would be hypovolemia. If the patient has either lost blood volume or lost fluid based on, say, nausea, vomiting, diarrhea, stomach issues, that would cause sinus tachycardia. If the patient is hypoxic and struggling to breathe, if their oxygen level is low, that could cause it. Stress or exertion. If the patient's under a great deal of stress, let's say we're on scene of a very bad wreck, and the patient is totally ambulatory, not injured, not complaining of anything. However, they've just watched a car run off the road and flip, or a car that's on fire. They're under a great deal of stress, so therefore this or exertion can definitely run their heart rate up. It's a natural fight or flight response. Another thing we can look at is infection or sepsis. So when you're evaluating a possible sinus tachycardia, look for your treatable causes and treat the underlying cause adequately. Again, hypovolemia, we can try giving a fluid bolus of 250 to 500 cc's based on your protocols. If it's hypoxia, if their O2 saturation is low or they're struggling to breathe, we can give them oxygen or possibly a breathing treatment to try to help them. If they're under a great deal of stress or exertion, possibly it'll come down to normal very quickly, or just getting them out of the environment. Infection or sepsis, we can start treating that. A lot of times, one of the early presentations of that will not only be elevated heart rate, but also concurrent hypovolemia. Any of these things can cause sinus tachycardia. If we think back to the beginning when we were learning about shock, one of the first things our body does to compensate for shock is elevate the heart rate to make it work a little bit faster. So this is showing signs of that elevated heart rate. It may be an early sign of shock or it may not be, but when we look at the overall situation and patient presentation, we'll be able to get an idea of what's going on with it. Also key to note, like I said, based on the environment or the situation the patient is in, just because they start out with sinus tachycardia, it may slow down to a normal 90 to 100 on the way to the hospital, just once they've had a chance to calm down from whatever the situation is. Remember, in many cases, the patient's under stress, there's an ambulance and a fire truck in their yard and a whole bunch of people coming in their house, and they're not feeling well, and someone's just called 911. It's going to get their heart rate up. So understand, while we look for treatable causes, anxiety and stress can be one of the most common ones, and we need to be aware of that. Also assess for other causes and treat them as we find them. Alrighty, now let's take a look at another rhythm. Alright, as we take a look at this rhythm strip, we kind of see that it's fast. We should by now be pretty well attuned to the fact that the more complexes you see and closer together they are, the faster the beats are happening and the faster the rhythm is per minute. So let's start off with our basics. What's the rate of this rhythm? Well, let's use the countdown method. If we start on this line right here, and we say, there's our first QRS, and the next one is right here, and the next one is here. So 300, 150, we'd say it's a little bit faster than 150 beats a minute. Well, that seems awful quick. Let's try counting it for 6 seconds. If we start from this marker here, and we come out 1, 2, 3, 4, 5, 6 to this marker here, we'll say, alrighty, how many QRS complexes do we have in that gap? Counting backwards, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18 QRS complexes in 6 seconds. Well, if we multiply that by 10, it would give us about 180. What we said before was between 300 and 150, so would 180 be appropriate? Well, yeah, it sounds like it could fit. If we look at what the rhythm's telling us now on the monitor, it's 180 beats a minute. Now, 180 beats a minute is significantly faster than what, 100. So we know this couldn't be normal sinus, but let's keep looking. We see the rhythm seems to be regular. The distance between any two QRS complexes seem to be about the same. They seem to pop up at regular intervals, no variance between the gaps on one to the other. And so now we'll say, okay, they seem to be regular, and what's the PR interval? Well, as we zoom in on it and look at it now, we see a PR interval between here and here appears to be about 2, maybe 2.5 boxes. I give it about a 0.10. Now let's look at the QRS width. It appears to be relatively narrow. It's between the two green dots there, about 2 boxes worth. So we'd say 0.08, which is less than the 0.12. So now we'll apply our next rule. Do we have P's for every QRS and QRS's for every P? Yes. We see P waves in here, and they seem to all look about the same. Even on the zoomed in one, they seem to be fairly similar. So now we'll say that yes, there's a 1-to-1 ratio of P to QRS, and QRS for every P. All the P waves appear similar. And so now we have to figure out what this rhythm would be. This rhythm's actual name would be supraventricular tachycardia. Now, this seems a little bit strange maybe because of the fact that we have, sinus tach or supraventricular tach. They're both over 100 beats a minute. The supraventricular tachycardia is much faster. You may also hear this rhythm referred to as just SVT. It makes it a little bit easier to get out, a little bit simpler to say. Both of these rhythms, sinus tach and supraventricular tach, or SVT, represent a rhythm that's faster than the upper limit of normal, or faster than 100. They both present with consistent P waves and PR intervals that are within the normal range. They both present with narrow, clean QRS complexes less than 0.12. But regardless of the similarities, there are some big differences between these, as they're caused by very different situations, and therefore as providers we manage them and look at them very differently. So let's look at each of them independently now and figure out what the differences are. Sinus tach is typically, again, over 100, and it goes up from about 101 to maybe 180. If you're dealing with a very young infant, it can be up as high as 220. Now, this likely indicates, as we said before, the patient's under stress, physical or mental stress that they're compensating for, hypovolemia or hypoxia. That's the body is trying to do something by elevating the heart rate in that first stage of compensatory response. One key difference is sinus tachycardia. The rate will likely vary with activity or posture. So if the rate is the same lying down flat as it is sitting up as it is standing up, That would lead us to believe that the rate's not going to vary with posture. It's not going to come down. Therefore, it's not the body trying to compensate for something. It's just the heart rate doing that on its own. On the other hand, if the rate varies from laying flat and it gets even faster when they sit up and even faster when they stand up, that would be an orthostatic change, which would be indicative that the body is actually compensating, therefore working harder and running the heart rate up higher when they're in a more upright position. That would lead us to believe it's sinus tach. Another issue we see that differentiates and helps us differentiate between these two is, what is the history? What are we hearing about from the patient or their family members? We can take two possible causes here and decide which one it would be. For example, if you're dealing with a young child and they can't tell you anything, however, the family states they've been sick for 2 to 3 days and they've been throwing up and having diarrhea and not been able to eat or drink much of anything, that would lead us to think they're possibly hypovolemic. The story would tell us which one we're looking at. If they're hypovolemic, likely we're dealing with sinus tach and we can treat the cause. On the other side of the coin, let's look at SVT. Typically, it's going to have a rate of over 180 or 220 in infants, and it's actually resulting from a cardiac cause or a re-entry mechanism within the cardiac conduction cycle itself. Now, at some of the very highest rates, we may not even be able to find P waves in there because the P waves will be washed out, made invisible by the QRS complex. A key differential is this rate will not vary much with activity because it's not trying to compensate for anything, so the activity won't cause it to change. So the rate will stay consistent whether they're laying flat, sitting up, or standing up. In this case, we need to actually treat the rhythm. So if we look at that child I was telling you about that's been sick for a few days and having a bunch of GI problems, we say possibly hypovolemia, and we'll treat the underlying condition. On the other side of the coin, if the child's been just fine and all of a sudden out of nowhere we're seeing a strange rhythm like this, we say, that could be the heart doing it on itself, doing it on its own, and therefore we would treat the rhythm. Now, differentiating between sinus tach and supraventricular tachycardia does take some time and practice to get used to. However, think about, what is the story? Does the story or the history of the incident indicate that this is something the child or the patient is compensating for? Or is the story or the history devoid of any possible causes? We're not seeing anything that would cause this, and therefore maybe it's a cardiac cause. Another thing interesting to note as we're discussing supraventricular tachycardia or SVT, it has an interesting brother. Now its brother is PSVT or paroxysmal supraventricular tachycardia. Yeah, I know, say that 3 times fast. Paroxysmal supraventricular tachycardia is SVT that comes and goes as the paroxysms of it. It starts on its own and it ends on its own. This can be very, very difficult for providers to identify. The reason is the patient will experience a run of SVT and they're having symptoms, maybe fluttering or tightness in their chest, maybe poor perfusion, near syncopal episode, lightheadedness, dizziness, all sorts of signs and symptoms. However, the rhythm resolves prior to the arrival of EMS. They can have runs of it for a minute or two and be done. And they say, well, I feel fine now, but, when I first called 911, I thought I was going to pass out. My heart was beating out of my chest. I couldn't catch my breath. It was awful, but then I sat down and everything resolved. Patients will have runs of PSVT, and a lot of times, if they're seen in the ER, even the ER doc says, well, I don't see anything now, but they've had this happen 2, 3, 4 times before. They'll typically be referred to a cardiologist. They may end up with an at-home Holter monitor or some type of at-home monitoring device that's designed to basically continuously record their ECG and try to catch one of these runs of PSVT when it happens. This can be common on teenagers and may be commonly seen especially on teenage females. I've dealt with several cases where everybody thought, oh, well, she's faking or there's nothing to it, but she was having consistent episodes, sometimes 5 to 10 to 15 minutes in length, where she felt like her heart was beating out of her chest, felt weak, dizzy, lightheaded, could not catch her breath, just knew something was wrong, but by the time EMS got there, everything was fine. Her story didn't yield anything as far as sickness or other issue or reason she'd be compensating, but eventually cardiology placed her on a Holter monitor. She was discharged home, and after that, sometime later was diagnosed with PSVT when the at-home Holter monitor caught 2 or 3 of these runs and were able to actually show what was going on. So again, we know that we have sinus tach, which is an elevated rhythm, typically up to 180 in adults, 220 in infants. We know that supraventricular tach is typically going to be higher than that. They're both narrow complex. They both got good P waves and QRSs, even though sometimes at very high rates we may not see the P waves. And our key differential is the patient assessment or the history of the event. So things to keep in mind as we address it. Now let's sort of wrap all these up together. In this module, we've discussed normal sinus rhythm. Its nice rate of 60 to 100. It's regular. PR interval, QRS, all within normal limits, and P waves, 1-to-1 QRS ratio and upright. If we change just one aspect of that, we end up with sinus brady, which is the same, it's just less than 60 beats a minute. Now, sinus arrhythmia may be normal or a little slow, but it's irregular. It's not going to march out. So that's the one criteria it's going to deviate from normal sinus rhythm. If we look at sinus tach, it's going to be over 100 and up to about 180 in adults. Again, it's still a regular rhythm, and all the other criteria meet the same. If we look at supraventricular tach, it's typically over 180. Again, it's still all the other criteria the same. And as we know, if you're on that border in the over 150 but under 200, and we're trying to figure out, is this sinus tach or SVT, default back to the patient's story and what's going on with the situation. We'll try to find out at that point, is it the heart running away, doing something of its own with an electrical reentry mechanism, or is it the heart responding to some other insult or injury that's going on with the body as a compensatory mechanism that we can treat and address? Now, this module covered some of the most common rhythms we'll encounter. While all of them have a similar origin, they all start in the SA node. The difference in rates and regularity causes them to be classified as different rhythms. Some of the rhythms in here may be perfectly normal for that patient. Hopefully, you'll discover that by objectively evaluating tracings based on our criteria, we can not only gain a great deal of knowledge for what the rhythm is itself and come up with a name for it, but also use the rhythm to determine what is or may be going on with the patient and come up with somewhat of a thought process of where we need to proceed with treatment. Alrighty, well, we're wrapping up this module. If you have any questions, as always, feel free to contact me. I've got my email up there on the screen. It's mike@valormed.net. I hope you've enjoyed this, and I look forward to seeing you in Module 2B, as we'll get into some more ECG rhythms and the criteria and the pathophysiology behind them.